Over 20 million people that are eligible for Medicare have some form of diabetes. That means 1 out of every 3 people are dealing with diabetes. In this video, I'm going to address the issue: if you have diabetes, should you have a Medicare supplemental plan? There are 4 different questions that I have to address in order to come up with this answer: do you need a Medigap plan in 2023 if you have diabetes? Question number 1 is this: do you have an employer insurance option? Now, you're eligible for Medicare at 65, but you don't necessarily have to go on Medicare if it's not in your best interest to do so. So if you have an employer option, you may not have to have any form of Medicare. So the way this works is if I have a group insurance plan, meaning there's 20 or more employees in that group, and so if I have this group, Medicare considers to be a large group, you actually don't have to do anything with Medicare A or B. It's not necessary to have A or B as long as the group is 20 or more. And so the way we look at this is we have to make a comparison between if I did go on Medicare versus staying on that employer-provided plan. And so the first thing is we know the size of the group. It has to be 20 or more, because if it's 19 or less that are employed in that company, you have to go on Medicare. But if it's 20 or more, we know then the next issue we address is, what is the price? In other words, what does it cost you in the form of premium to actually be on that employer-provided plan? Now, my general rule of thumb is this: if you have a good plan, meaning you have a deductible of $1,500 or less, and that premium is costing you no more than, let's say, $200 to maybe $250 a month, so $200 to $250 or less a month, that's a good plan, then I wouldn't do anything with Medicare. In other words, if you have diabetes and you have a good insurance option at work, then keep that plan. You can stay on that plan until you decide to retire. Now, by the way, that insurance option at work could also be your spouse's employer-provided plan. So you or your spouse covered by the employer-provided plan. If it's a good plan, and again, the premium is $250 or so a month or less, then staying on the plan may be in your best option. Okay, so we look at the premium. Now, let's say the premium is around that $250 range. Then what I look at is, what does it actually cost to be on the plan? In other words, what kind of co-pays do you have, and what is your max out of pocket on that plan? So diabetes sometimes can be very expensive just because of health issues that come up. And so if you have a max out of pocket, let's say on that plan that's going to be maybe $2,500 a year or more, then you may want to look at Medicare as an option. But if this, again, is very low, maybe nothing more than a small deductible, then again, the insurance option at work may make sense. But if I have a high max out of pocket, then I'm also going to look at the prescriptions. In other words, what does it cost you for your diabetic medications? Now, I'm going to look at here in a few minutes how Medicare covers those, but I'd like to know exactly how that group plan is going to cover those. And so, again, if we have a group of 20 or more, and this insurance package at work, or your spouse's work is very attractive, then you don't have to do anything with Medicare. Now, some people will tell you that you have to enroll into Medicare A, and they would say you have to take A only. But I want you to realize that you don't have to take A if the group is 20 or more. Now, if you do take A, it is fine to do so. However, if you're contributing to a health savings account, that's an HSA, then if you enroll in A, you can put no new money into your HSA account. So again, if you have an HSA, I would not enroll into A or B if I have a good insurance option at work. Now, let's suppose that you don't have an HSA, but you do like the insurance option at work, and you enroll in A only, then that is a fine thing to do. However, you got to be mindful that in this A only position, with a group of 20 or more, then Medicare only pays second. Your group plan will continue to pay first. And then if there's a remaining balance, specifically for co-insurance, then Medicare pays something. But as a general rule of thumb, Medicare really is not a very good secondary payer. But if you do go ahead and enroll in A only, it's fine. As long as we don't have an HSA, there's usually no premium for Medicare A. But again, it's going to be in the second payer position. So that's question number 1. Do you have a great insurance option through you or your spouse's employer? Hey, if you're finding this video helpful, I want to invite you to go right up here and actually click on a link that will allow you to watch what I call the Medicare Essentials Workshop. It's a workshop that I did that really is going to show you everything you need to know about Medicare from A to Z, how to enroll, when to enroll, and the plan options for you. So go to that link and check it out. Question number 2 that we need to address is this: do you need to enroll into Medicare? So if I have a group of what? 20 or more, and that insurance option at work is not very good, it's high in premium, it's high deductible, possibly high max out of pocket, then you may need to enroll into Medicare. But if the group is 19 or less, you absolutely must enroll into Medicare A and B. So do you need to enroll into Medicare A and B? If the group is 19 or less, yes, you will. Now, let's suppose neither you or your spouse are working, so we don't have an employer option. That means that you're covered probably by some kind of a retiree plan. You may be covered by COBRA insurance, or you may be covered by an ACA plan, an Affordable Care Act plan. Those are the most common forms of insurance today. Also, I forgot, you may have TRICARE, which means you're retired from the military, or you may have FEHB benefits if you are retired from the federal government. Okay, so those are the different insurance options. So what I want you to realize is this: if I have any of these 5 options, I am going to enroll and actually must enroll into A and B. Now let me address the Affordable Care Act plans. You technically can keep an Affordable Care Act plan when you're eligible for Medicare. The problem, however, is this: all the benefits of that ACA plan, which typically includes a large amount of tax subsidy, also cost sharing, which means you have minimal out-of-pocket, very little premiums if you get a tax subsidy. Those things go away once you're Medicare eligible. And so you can keep the ACA plan, but all the financial benefits to you are going to go away. So I've yet to see a reason why someone would keep an ACA plan once they're Medicare eligible. So basically what they do, by taking away all those extra benefits, they're de-incentivizing you for staying on the ACA plan. Okay, now, if you have retiree plan, COBRA plan, TRICARE, FHB, then you also have different options. So here's what I want you to realize: if you have a retiree plan, you must go on Medicare A and B. And the reason for that is because that retiree plan is getting you to Medicare eligibility. But after Medicare eligibility, that retiree plan, if you decide to keep it, will only pay second to Medicare. So you must enroll into A and B if you have a retiree plan. Now, sometimes those retiree plans are attractive. Usually they're not, but sometimes they are. But regardless, we've got to enroll into A and B if we have a retiree plan. Secondly, if you're covered by some kind of a COBRA insurance, typically COBRA is for those that have lost their employment or their spouse has lost their employment, and now you have this COBRA insurance option. In other words, there's no active employment involved. Same thing happens. You're going to have to enroll into A and B when you're eligible at 65, because why? That COBRA plan will no longer pay in the first payer position once you're Medicare eligible. It will continue to pay, but it only pays second. And so you have to enroll into A and B, and if you don't, now everything that A and B would pay, you'll be responsible for that. And a lot of folks don't realize this. So here's my point. If you have COBRA insurance, you've got to go on Medicare at 65 to put Medicare in the first payer position. You can keep COBRA if it makes sense for a short period of time, but again, it will only pay second to Medicare. Now, when it comes to TRICARE, now someone that's on TRICARE, what this means is they were in the government, they served in some branch of the armed services, and they had TRICARE. Now, once you're eligible for Medicare, what happens is TRICARE becomes TRICARE for life. But again, you have to enroll into A and B because TRICARE, once you're Medicare eligible, only pays second to Medicare. So you enroll into Medicare, putting them in the first payer position, and then TRICARE then will pay second. All right. And then next, when it comes to FEHB, this is federal employee health benefits. I'm talking about people that have retired from the federal government. Now, you are very unique, and again, I got a lot of teaching on this, so I just want to highlight one thing. On the FEHB plans, you actually are able to enroll in A only and then keep your FEHB insurance. Could be Blue Cross Blue Shield, could be GEHA, could be Humana, Aetna, some other coverage. But the point is you actually can have A only. Now, I'm not a fan of A only, and here's why. Because if you have A only, that's only going to cover the hospital side of your benefits. And now what's going to happen for all the doctor services and everything outpatient, you're still going to have some cost out of pocket, some co-pays, some co-insurance, some max out of pocket that you'll be liable for because you didn't take the Part B. So I think it's smarter to enroll into A and B, and then if you want to keep FEHB, put them in the second payer position. And yes, you're going to have to pay that B premium, but I think for a couple $1,000s for the whole year, what you'll spend in Part B far outweighs your liability and the out-of-pocket expenses you could be subject to if you had FEHB and A only. So I like A and B, and then use your FEHB. Now, some people that are on FEHB and they enroll in A and B, what they will do is they'll actually do what's called an MA only plan. And I'll talk about these here in just a few minutes, but this is a very unique option for you. You can do a Medicare Advantage only plan, and then you can continue to get your prescriptions, especially if they're diabetic medications. You may find it's favorable to get those through FEHB and then use on the in and outpatient side a Medicare Advantage plan. So again, that's a unique option for those of you that have FEHB. And again, I've got a lot of YouTube video instructions for those of you that have that option. But here's my point. The question is, do you need to enroll into Medicare? And there are times when you absolutely must. Group is 19 or less, on a retiree plan, COBRA plan, ACA plan, and TRICARE for life. Yes, you're going to enroll into Medicare. Now, if you're already receiving Social Security, you are automatically going to be enrolled into Medicare. In fact, the Medicare card will be mailed to your home about 100 days prior to when your Medicare coverage is going to begin, just a little over 3 months prior, all right? And so you'll be automatically enrolled, and you're going to get a Medicare card that is going to be A and B. Now, keep this in mind for those of you that may be receiving Social Security. You get the Medicare A and B card. You don't have to stay enrolled in A and B if you have that group that's 20 or more and you're still covered by that employer-provided plan. You actually can mail the card back in, they'll drop off the B, and they'll send you a new card that'll say A only, and then when you lose that group plan that's attractive, then you can pick up B at a later date. But if you're on Social Security, that A and B card is going to show up. Now, the majority of you are going to keep the A and B benefits because you're not going to have a good employer option available. But if you do, again, send it back in. So if we're on Social Security, we're automatically enrolled. But if we're not on Social Security, then you are going to have to self-enroll. Self-enroll, right? And the way we do that is, first thing we do is we set up an SSA.gov account. Very first thing. It'll take you about 10 or 15 minutes to set that up. Be sure to keep your username and password, because every time you want to go in and look at your Social Security or Medicare records, you can get access to all the information on that website as long as you have your username and password. So once we actually have set up the SSA.gov account, now we can enroll online. Okay, and you can enroll into Medicare A and B online. It's very simple to do. This takes about 5 or 6, 7 minutes or so, not very long, and you can do that. I'm going to show you, though, the key to doing it at the right time in my next slide. So enrolling into Medicare at the right time is critical. Now, I'm shooting this video today. It's actually October the 17th. It's Monday of 2022. Now, the rules are getting ready to change with Medicare enrollments beginning effective January 1. So I'm just going to tell you about the new rules, because most of you that are going to start Medicare still in 2022 have already made those decisions. So again, this is all about the new rules in 2023. So here's what happens. When we self-enroll to Medicare, and we're going to start at 65, we call this your initial enrollment period. Now, the initial enrollment period now and always has lasted 7 months, and in the future, it's going to last 7 months. And when we enroll into Medicare, it determines when they start our coverage. And that's one of the changes they made. So let's say that my birthday is, let's say it's January the 3rd, 1958. Okay, and I am self-enrolling into Medicare because I have to at 65. So I have 7 months to enroll during this period of time, 7 months. So here's those 7 months. Here's the way it works. So my birthday, my eligibility for Medicare is January 1, 2023, because my birth month is January 3rd. So I have 3 months before, and I have the month of my 65th birth month, and 3 months after. So this would have been December, this would have been November, this would have been this month, actually in October. And then I have 2, 3, and then April. So here's what happens. If I enroll these first 3 months of my IEP, my enrollment into Medicare, again, I go to SSA.gov, set up that account, and do my A and B enrollment, my coverage will start January the 1. Okay, so these first 3 months, effective date would be 1/1/2023. So I have an A and B date of 1/1/2023. But if for whatever reason you decide to enroll in Medicare during your birth month, then your coverage is going to start the next month. This is one of the changes that has come about with the Medicare rules for 2023. And so if I enroll in January, they start me in February. If I enroll in February, they're going to start me in March on my Part B. If I enroll in March, they're going to start me in April. If I enroll in April, they actually will start me in May. And that would be my last month that I can enroll. So all I'm saying to you, if I decide to enroll my birth month or thereafter, they start your coverage the very next month. So that's what I'm saying. Do you need to enroll in Medicare? You want to make sure, if you need to, that you do it at the right time. Now that brings us to our third question then. What are our Medicare options for diabetic coverage? And what I'm specifically addressing here would be in and outpatient services. So this means if I have to go to the hospital, I have to go to the doctor, I have to see my endocrinologist, a specialist, we want to make sure that we know what our options are for that in and outpatient coverage. Okay, so first off, big picture, we have the options to get what are called Medicare supplemental plans. They supplement original Medicare, or we actually can get what is also called a Medicare Advantage plan. All right, Medicare Advantage plans. All right, now, when it comes to supplemental plans, the people that decide that that's the way they want to use their coverage, what they're doing is they're enrolling in A and B, and what's going to happen? A and B is going to be the first payer, and then your Med Sup plan is going to pay second. Now, why would we need a secondary payer? Why would we want to get a Medicare supplemental plan? Well, the reason for that is because original Medicare A and B has gaps in the coverage. There's gaps. In other words, Medicare pays, but other than preventive services, Medicare doesn't pay for anything 100%. You're always going to have a balance of the bill. There's some financial liability, financial exposure that you have. Those are deductibles and co-pays and co-insurance. So you will have some liability in original Medicare A and B. And so if you don't like that liability, you actually can transfer that liability to a Medicare supplemental company. So let's quickly review the gaps in original Medicare. There's actually 3 on the A and 3 on the B. So here's the way this works. The A of Medicare has a deductible, and all this is going to be for 2023 numbers. The A deductible is $1,600. And that just simply means if you go to the hospital, you will spend $1,600 in 2023. And that deductible actually covers you for all the way up to a 60-day stay in the hospital. That's all you have to pay. So from days 1 to 60 in the hospital, that deductible covers your total out of pocket. The bill could literally be 50 grand, the bill could be $1 million, doesn't matter. As long as we're just in the hospital between 1 to 60 days, that's all we'll have to spend is the deductible. Now that's going to cover, frankly, about 99% of every situation. But there are times when people are really ill and they're in the hospital longer than 60 days. So here's what happens. Now we have what we would call A copays. And these are to the hospital. So this is what the hospital is going to charge you. And so what happens is days 61 to 90, next year, 2023, the daily copay is going to be $400 a day. Okay? Days 91 to 150, that copay doubles, and now it's going to be $800 every single day. So this is the second gap that's in the Part A of Medicare. It's hospital copays. So you're responsible for these daily copays. Now again, those don't happen often, but when they do, as you can see, they're expensive, but you would be out of pocket on those items. Now the other item that we're responsible for on the A of Medicare would be to a skilled nursing facility. This is after someone's had a stroke, maybe a hip replacement, and they're going to skilled nursing for fairly intensive rehab. So here's the rules. Medicare says from 0 to 20 days. The first 20 days, as long as you were in the hospital, this period of time here, you're in the hospital at least 3 full days, 72 hours, 3 complete 24-hour periods, then Medicare says that you can go to skilled nursing for the first 20 days and it does not cost you a penny. But if I'm still in need of skilled nursing care from the 21st day for the next 100 days, now I'm responsible for a daily copay of $200 every single day. Okay, $200 a day. And so I have 80 days of coverage, but if I get beyond that 21st day on, now it's going to cost me out of pocket $200. They say right now the average stay is about 30 to 35 days. So most people are spending anywhere from about $2,000 to $3,000 out of their pocket. And my whole point is this. If you decide to stay in original Medicare to get our issues with diabetes covered, if we ever go to the hospital, it's going to cost us $1,600. That's the first 60 days. If I'm still in after that, I now have these daily copays. And then thirdly, if I'm going to be in the a skilled nursing facility, after 20 days, it's going to cost me $200 every day. So you're liable for these. Now, we can get rid of that liability if we buy a supplemental plan, but if we don't, then we're going to have that financial burden placed upon us. All right, so those were the gaps that are on Medicare A. Now let's talk about the gaps that are on Medicare Part B, the B gaps. Again, there's 3 of those. The first gap is a B deductible. This year, that actually is $233. In 2023, it's going to go down to $226. Now, the good thing about that deductible, it can only happen once a year. That A deductible could happen multiple times in a year, but the B deductible, once a year, a calendar year, and then that number resets every January. Again, today's October 17th, 2022. This actually is $233 for this year, but they decided next year in 2023 to lower that deductible a few dollars. So once we've met the $226, that takes us to our next gap on the Part B of Medicare, and that is called coinsurance. Coinsurance, okay? And what is that? That means Medicare pays 80% and you pay 20%. Coinsurance is going to be your responsibility, so that's your second gap. Now, when we talk about out-of-pocket expenses for healthcare, we have copays and we have coinsurance. A copay is a flat dollar amount. It could be a $5 copay, $50 copay, $300 copay. When it comes to this B of Medicare, once I've met my deductible, then I go into coinsurance. So it's a percentage of the bill that is going to be remaining would be your responsibility. And then the last gap on the B side is called excess charges. Excess. Now, just so you know, the only people that can actually charge excess charges would be doctors. This would be specialists, primary care doctors. They're the only ones that can do this, and that just simply means that they add 15% to the Medicare bill. And so there are some doctors that don't do that. In fact, most doctors don't do that, but there are some that actually add the 15%. And so that's going to be our third gap. So I meet my deductible, I got to pay my 20% coinsurance, and then I'm responsible if and when I go to a doctor that adds to the bill, you have to pay the excess charge of 15%. So again, those are going to be our three gaps on the B of Medicare if you decide to stay in original Medicare and get a supplemental plan. Hey, we really appreciate you taking the time to watch these YouTube videos. And because of that, we have a free gift for you. And if you'll click right up here, you'll just have to give your name and email address, and we'll send that free gift right out to you. Now, the majority of people that are deciding to stay in original Medicare A and B with a supplemental plan are either getting an F plan, a G plan, or an N plan. Those are the top three plans today. I'd venture to say probably 95 to 97% of all people have one of those three plans. And so the F plan is truly a full coverage plan. Remember the gaps we had? There were 6 of them. That F plan covers 6 of the 6 gaps. In other words, someone that has an F plan should never get a bill, because if there is Medicare pays first and there's a balance, then that F plan, will cover that full expense. All right, 6 of 6 gaps are going to be covered. Right? Only thing you have to pay is the premium on the plan. Now, the issue with the F plan, and some of you would already know this, but some of you maybe not, the only people that can actually buy the F plan today are those that were born before January 1st, 1955, which means they were eligible for Medicare prior to January 1, 2020. So if I was prior to that, you can still get an F plan. But if I'm born after that, you cannot buy an F plan today. Now, those who have F plans can keep them. Anyone, again, born before 1955 can buy them and keep them their whole life. They're not going to lose them. That group was grandfathered in when they made the changes just a few years ago. So if I'm born after January 1st, 1955, the most popular plan is the G plan. Now, the G plan, notice this, covers 5 of the 6 gaps. Okay? It covers all the gaps except one, and it does not cover the B deductible. That's once a year. Remember what I said? This year it's $233, and this year, 2022, next year, it's $226. And again, that's the only gap it wouldn't cover. Once I've met that B deductible, which means the first $226 on the B side of Medicare, doctor services and everything outpatient, then I have a full coverage plan. It will absolutely cover 5 of the 6 gaps. All right, now the N plan is the next plan in line. Not as popular today as the G plan, but some people are opting for the N plan, going to have a little bit of a lower premium. So what happens on the N plan is this: it covers 4 of the 6 gaps, plus you also have some copays. Okay, so 4 of the 6 gaps are covered. So again, that N plan will not cover the B deductible, just like the G does not, and it also will not cover excess. All right, so if you happen to go to that doctor that adds the 15% and you have that N plan, you will pay that extra 15% out of pocket. Plus, every time you see a doctor, you're subject to a $20 copay, and anytime you go to the emergency room, you're subject to a $50 copay. So we got a few extra copays that will be our responsibility as well. But you can see what I've done. I transfer the liability of the gaps to the insurance company. If I want full coverage, it's the F plan. Unless you're born after 55, then you can use the G and get rid of all but that B deductible if you do the N. Again, we're going to have that lower premium, but you're going to take on some more liability. Now listen, folks, we're a nationwide company, and so I'm just going to broad stroke this just to give you some kind of a general feel for the way this works. Most F plans today are going to be in the neighborhood of somewhere about $170 to $200 a month, okay? And again, this is going to vary state to state for sure, but as a general rule, that's a good average. The G plans right now are going to be anywhere from about $120 to about $150 on a monthly basis. Your N plans are going to be somewhere probably about $85 a month to maybe $115, all right? And so as obviously as my premium goes down, I'm taking on just a little bit more liability. But this is one way that you can get your diabetic coverage, your healthcare service, your inpatient and outpatient covered. You can use a Medicare supplemental plan and pay a premium so you can get rid of the majority of that liability in case you're hospitalized or you have to see your doctor and you're having some issues with your diabetes, sugars are off, or maybe you end up have some kind of a neuropathy or a retinopathy, but you have complications. This is one way you can get that inpatient and outpatient services covered. Now, the second way that we can get coverage for our diabetic issues as it relates to in and outpatient is to do a Medicare Advantage plan. So if we opt not to be in original Medicare with an A and B and a supplemental plan to cover the gaps, now we enroll into an Advantage plan. There's actually 3 different ways in which you can get Medicare Advantage. One of these is called MA only. And that just simply means that you do not have built into that coverage a prescription drug plan. Now, folks, the only ones that should do that or even consider doing this would be those that have TRICARE for life. You get your prescriptions at the VA. In other words, you qualify for VA benefits, or you're retired federal government and you have the FEHB system to get your medication. So if I get my meds from TRICARE, VA, or FEHB, then you can do what's called an MA-only plan. And there's a lot of perks that go along with those MA-only plans. But if you're not in one of those 3 categories, you should not do that. You then would get what is called an MAPD plan. So the Medicare Advantage portion is our inpatient and outpatient that I'm getting ready to teach you about, and the prescription drug plan is that Part D plan that's included or embedded within the MAPD plan, and I'll address that here in just a couple minutes. So right now, let's just talk about if we have this Medicare Advantage plan, how is that going to work? So here's the way Advantage plans work that would be different than a MedSup option. The first thing we're going to have to see that's different is if I have an Advantage plan, you're always going to have some kind of a network of providers. These are going to be either HMOs or they're going to be PPOs. Now, the differences are a couple. Number one, when the companies put together their Advantage plans, you'll find that the HMOs are going to have lower copays as well as lower max out-of-pocket. The PPO costs you a little bit more when it comes to copays, but what you're going to find is your PPO networks are going to be much larger. And the simple reason for that is that the PPO contract pays the provider more money. So more providers, more doctors and hospitals are willing to go within the network. But you're going to notice that these are always a little bit more attractive financially for you, but the PPO is a little bit more attractive financially for the provider. So that's why there's a difference in the size of the network. And so when I describe the network, I would say there's the HMO, and over here is going to be the PPO. So we're certainly not going to have as many options. Now, you may be in an area where there's plenty of options, and all your doctors could be covered by the HMO. So it doesn't make the HMO bad. It just means that there's typically going to be more providers in the PPO. Okay, so that's one issue. The other issue has to do when it comes to these plans. Not only are we going to have networks, but we also have to realize that with these networks, we're going to pay for our plan as we go. So we pay as we go. All right? So that means that for the cost of my services, that will be determined on how many of those services I need. If I have a MedSup option, I paid a premium to the insurance company, and after that I had very little out of pocket. So the way these plans work, Medicare Advantage, is a pay-as-we-go system. So the first thing we have to pay, we're enrolled in A and B. That's what qualifies us to have one of these plans. So I got to pay my B premium. This year, in 2022, that's $170.10 a month. Next year, it's going to $164.90 a month. Okay, it went down just a little bit. And so if you're on Social Security, that premium comes out of your Social Security check. If you're not, they'll bill you for that quarterly, or they'll set up some kind of a bank draft for you to pay that monthly until you go on Social Security. So here's my point. It's a pay-as-we-go system. So to have an Advantage plan, I've got to be enrolled in A and B, and I've got to pay that B premium. And then my pay-as-we-go is going to be this. If I see my primary care physician, my PCP, probably a zero copay. Most plans doesn't cost you anything to go to your primary care doctor. Now, when I see a specialist, well, that's going to be anywhere from about $25 to $50 copay whenever I want to go see a specialist, my endocrinologist or some other kind of specialist. If I have to have an MRI or a CAT scan, probably going to cost me $150 to $250. If I go to the hospital, it's probably going to cost me anywhere from $300 to $400, and I could go on and on. But the whole point is, you understand, is that we pay copays. And all these copays are going to go until we hit what is called the max out-of-pocket. Now, again, this is going to vary. HMO versus PPO, different parts of the country are going to have different max out-of-pockets. But as a general rule, those HMO and PPO plans are going to be somewhere in the neighborhood of about $3,000 to $7,000 out of pocket. So you could be subject to copays up until you hit that limit. And then once we hit that limit, we're done. We can put the checkbook away, put your wallet away for the rest of the year, because that's all we'll pay until December 31. And then in January 1, those max out-of-pockets reset again, and then we start paying our copays, which are applied to the max out-of-pocket. So once we reach max out-of-pocket, we're going to be done. All right? And so that's the difference between them. We have a network plan, and instead of paying a premium to the insurance company, we pay Medicare, and then after that, we just pay as we go for our health care services. That takes us then to the third part of these Medicare Advantage plans. Let me explain. So this third aspect that you have to be aware of as we compare these two different options for our diabetic coverage is this concept of pre-authorizations. Pre-authorizations. Now, as we talk about pre-authorizations, let me explain what that is. This is some type of a healthcare service that you need that is kind of more on the expensive side. You do not have to have a pre-authorization to see your primary care doctor or to see a specialist or to have lab work. But when it comes to any kind of a hospitalization, any surgery, whether that's inpatient or outpatient, a skilled nursing stay, an MRI or a CAT scan, there's about 70% of all the services you need are going to have to be pre-approved. So that just simply means the doctor says you need X. And so if it's a pre-authorization type of service, doctor says you need it, and then they have to get the approval of the insurance company before you get that service. So there's a process, paperwork involved in a short period of time, and they'll notify the insurance company saying, hey, we need a knee replacement, hip replacement, whatever we need. And so that insurance company will look over why that service is needed, the doctor's opinion about it, and if they agree with that opinion, they will approve of that healthcare service. That pre-authorization went through. But there are times when they'll look at that pre-authorization and the insurance company says, no, we don't agree with what the doctor is saying, and we are not going to cover that knee, that hip replacement, whatever it is. And so now that coverage is denied, and they have every right to do that. Now, you also have the right, if they deny, to appeal that to see if you can get a reconsideration. But I've seen plenty of times when people are not able to get certain services that they want. And my whole point to you is that if you take a Medicare Advantage plan, we have networks, we pay as we go, but also we have to live with the pre-authorizations because, again, 70% of the services will have to be approved by that insurance company, which just simply means that the doctor does not have the final say-so in the Medicare Advantage system. It's the insurance company that has to approve it, so they truly do have the final say-so. Now, as we compare that to Med-Sup plans, if I go with this option, there are no pre-authorizations whatsoever. If the doctor says you need it and Medicare says we'll cover it, end of story, that supplemental plan has no say-so whatsoever. And that's the way supplemental plans work. If Medicare pays, your supplemental plan will also pay based upon the letter that you bought. If Medicare doesn't pay, they're not going to pay. But as long as Medicare pays, they have to pay. So that supplemental plan has no right whatsoever to deny you any coverage. If Medicare covers, they have to cover. And then that takes us to the final aspect as we talk about this diabetic coverage for in and outpatient, whether I get a Med-Sup plan or a Medicare Advantage plan. And that is the time frame of these plans. In other words, are these plans permanent? Now, when it comes to a Medicare supplemental plan, a Med-Sup plan is permanent, okay? Which means what? That means that policy is literally written for life. Once they have approved that policy, they can never cancel a policy except for non-payment of premium. They cannot cancel it because you have a lot of claims. They cannot cancel because you're getting old. They can't cancel because you move away. In other words, that policy is totally yours, non-cancelable by the insurance company except for non-payment of premium. Now, here's what you got to realize. Because you have diabetes or you're concerned about that, you also have to realize that once that policy is written, regardless of what would happen with your diabetes, they still have to cover all those issues, your pre-existing conditions, everything. Now, what happens is this. Let's say we start our Medicare Part B. Let's say we start it this next month, 11/1/2022, all right? We are in this window of what Medicare calls a guaranteed issue or a Medigap open enrollment period, but it only lasts 6 months. 6 months. So if my Medicare B date is going to be 11/1/2022, I actually can apply for a Medicare Supplemental plan 6 months in advance. But once my B start, I am still in my Medigap open enrollment period called the guaranteed issue for 6 months. So that would be what? December, January, February, March, April, May, which means what? June 1 of 2023, moving forward, in most states, if I ever want to pick up a supplemental plan now, you got to go through medical underwriting. Now, they can take, some insurance companies will take you with diabetes, but if you take too much insulin, they will not. If you have any kind of diabetic complications, such as retinopathy or neuropathy or an amputation or a diabetic coma, they will not take you. But during these 6 months, the 6-month window, 6 months before we start Medicare, 6 months after the B date, in my example, all the way up to May 31, we are in that period where they have to take your diabetes, your complications, even if they're very severe, they have to take those during that period of time. But again, in most states, if I want to get a policy after that, now I've got to go through medical underwriting. We're going to ask you 25, 30 health questions, check all your medications, and now that insurance company, that MedSup plan, can say, no, we're not going to approve that policy. This is a very, very important window. Now let's talk about Medicare Advantage plans. First off, you can get a Medicare Advantage plan when you first come onto Medicare. So let's say I'm coming onto Medicare and I start my Medicare B 11/1/2022, excuse me. Okay, you can have an Advantage plan because there's no health questions asked whatsoever, all right? And so that policy is yours. But the difference is it is not going to be permanent. Advantage plans are only for 1 calendar year at a time, 1 year. And so what happens is that that Advantage plan actually does not even have to offer their plan in 2023. It's available now, but they actually can change anything they want from year to year to year. So again, these are permanent. These are not. These are 1-year contract between Medicare, the insurance company, and you. And that's why we have this season where people can switch the plans. And that season is from October 15th through December the 7th. And then we have another one, January 1 to March 31. So we have these few months every year that if we want to switch Advantage plans, we can make those switches because those are only good for 1 year at a time. So if your plan changes or your doctor leaves the network or you're no longer happy with the HMO and you want to move to a PPO or vice versa, then we have this window period of time where we can switch our Advantage plan. So that, again, that's a difference. So when you make this decision, you're deciding, am I comfortable with the network if I take an Advantage plan? Am I comfortable with the max out of pocket of my copays? And am I comfortable being on a plan that is subject to change on an annual basis? But you're going to have to make a decision when you go on Medicare for your diabetic coverage. It's one or the other. Cannot have both. You got to make the decision. Now, the fourth and final question that I want to address as it relates to your diabetes, and that will be your medications. All right. And so if you decide to stay in A and B, and you get a supplemental plan, that F plan, that G plan, whatever you decide to get, you actually are going to then get a separate drug plan, okay? These are called Part D plans. These are separate plans. We call them standalone plans, all right? And in most markets, there's going to be anywhere from 15 to 25 different plans to choose from. Now, you got to keep this in mind. A and B will cover medications, but only those that are professionally administered. That means you get them in a hospital or you get them in an outpatient facility, those kinds of things. Or, by the way, if you're a diabetic that uses an external pump, Part B will also cover your insulin as well. But the whole point is this. When I have A and B, I add a supplemental plan to it. For all the meds that I self-administer, I'm going to have a separate drug plan. All right? Now, if I decide to do the Medicare Advantage, what's going to happen? I can have an MA-only plan, which means what? all my diabetic medications, I'm going to get through who? I'm going to get that through VA, I'm going to get those through TRICARE for Life, or I'm going to get those through the FEHB system, GEHA, or Blue Cross Blue Shield, right? So I'm going to use those instead. But here is my in and outpatient. For those of you that don't have that as an option, we're going to get the MAPD. So what happens? In and outpatient is the Medicare Advantage. Now we have this Part D plan included. Now, in this system up here, you pick the plan. It's a separate plan you chose based upon the meds you take and the pharmacy you want to go to. In this system, they include it. It's part of the package. You didn't choose it. You chose the plan, and they chose the prescription drug component that's built within that. And again, some of them are very good, and some are kind of mediocre, but we got to make sure that we have proper drug coverage regardless of how we go, okay? So depending upon which system that you decide to use for your in and outpatient will determine your options when it comes to prescription drug plans. So when we select our drug plan, whether that's embedded within the Advantage or it's a standalone drug plan because we went with the MedSup option, there's components of that drug plan that you have to be aware of. The first thing and most important thing is the formulary. The formulary is simply the list of medications that will be covered by that plan. In fact, this is the most important part of that decision. You want to make sure that your medications are in formulary if that's at all possible. So once we look at the formulary, then we look at what's it going to cost us out of pocket. And that is typically going to be some copays, but those copays are going to be based upon the tier of the medication. So every medication covered is given a tier number, 1, 2, 3, 4, or 5. And the lower the tier, the lower the copay, but that sets your max out of pocket. Now also, some of the plans have a deductible. Now Medicare sets that deductible. In 2023, it's going to be $505. And that just simply means that the cost of your medications in that deductible stage will be applied to the deductible. And some people never even meet their deductible. But if you're on some expensive medications, it's very likely that you will meet that deductible. And then after we meet that deductible, then we just simply have copays, okay? And the good news is that beginning in 2023, we have a new program that Medicare has put forth. They've actually been testing it since 2021. And now what's happening is some of the formularies are going to include some reduced costs for insulin, all right? There's actually 5 manufacturers that are participating in this particular program, okay? And so we're going to have insulin, some insulins that are going to be now very stable in price. You don't have to worry about them fluctuating. And so the rules are this: if that insulin you're on is in formulary, the most you would pay for that insulin is $35 a month. Okay, $35 a month, a month's supply of that insulin. Could be Novolog, could be Humalog, could be Lantus, Novolin, Humulin, those kinds of meds. So we have $35 max. Now here's what you got to realize. Not every plan is participating in this low copay plan. Certainly some are not going to, but some are. And so it's nice to be able to find a plan where the max for your insulin is going to be $35 a month. Not every insulin is covered, not every plan is going to have it, but there are some that are. And so you want to be sure to be enrolled in those kinds of plans. Okay, and that $35 has nothing to do with the deductible if your plan applies. If you ever get to the donut hole, that would never affect it either. You just pay that fixed copay throughout the year, $35. All right, and so that's really a neat thing. And so if I get a standalone plan, I can find a plan that participate in those reduced insulin prices, or if you get a Medicare Advantage plan, some of those plans are also going to be participating in the reduced insulin prices as well. Okay, and so this is a real big deal because you want to make sure that you have a very good prescription drug plan, whether it's embedded or it's going to be separate, to make sure you keep down the cost of your medications. I also want to make you aware that with all the plans, there are 2 items that every plan can have, and that is called step therapy, and prior approval medications, okay? Prior approval. So a step therapy medication means that there are several medications that can be used to treat that illness, that disease. And some of those are probably lower cost generic type medications. And so if the doctor prescribes, let's say, a brand name medication, and there's some lower cost meds in the formulary, then because of step therapy rules, you may have to try those lower cost meds. Now, if you've already tried them before, the doctor can say, hey, they'll simply don't work, and you'll probably get the brand name medication filled first. But if you never have, then you're going to have to step therapy. You have to go through those different steps before you'll get the brand name medication. Now, prior approval just simply means that that is a medication that is very expensive, and in order for that plan to actually fill that medication, the doctor has to fill out certain paperwork, and then what they'll do is they will, if they agree that you need it, then they will approve that medication and they will add it to your formulary for that given year. But these are different ways in which Medicare allows these plans to do some controlling of their cost by initiating step therapy and prior approval procedures.
Hey, if you're looking for someone to help you hold your hand through this entire Medicare enrollment process, we would love to do that. Our team is standing by to help you. We help about 1,000 people a month go from Medicare confusion to having their plans enrolled, and it takes probably less than an hour. Go to the pinned comment below and you can book your appointment.
And then lastly, I just want to make sure that you're aware that all prescription drug plans have 4 stages, which means each of the stages you can have a different copay except for your insulin. The good thing is if you're on that $35 insulin plan, that'll be the same throughout the year. But if you're diabetic, you may have other issues. And so I want to make sure as you look at the cost of your medications, you're clear with the stages. Okay, so stage 1 is the deductible stage. And remember what I said, in 2023, that's $505. It doesn't necessarily mean that you got to write a check for $505. It just simply means that the cost of your medications, whatever they are, is applied to the deductible in that stage. So let's say we meet our deductible of $505. That then takes us to stage 2. And Medicare calls this the initial coverage stage, just initial. And what this simply means is you have some very, very reasonable copays that you pay. Let's say if you're on a medication that retails for $500, your copay in this stage may be $50. You're paying about 10% of the cost. Okay, so very reasonable. But here's what's happening in this stage here. Medicare is tracking the full retail cost. And if that full retail cost of all your medications that you've gotten will ever reach what is called the threshold, the retail threshold. So again, this is retail cost, not what you paid, because you paid a very reasonable copay. The plan you're on paid the difference. So it's basically what you're paying and what they're paying to make up the difference is the retail. And the retail threshold next year in 2023 is $4,660 in retail. Now keep in mind, if you're on that insulin program, that doesn't apply. You still pay at $35. So that insulin cost is not going into the $4,660. But all your other medications are going into that number. And so if we ever reach that number, what happens? That takes us into stage 3, which is called the coverage gap, or we just call it the donut hole, all right? And so now we're in the donut hole. And again, it won't be your insulin that's covered that's going to put you there. It could be your other medications, maybe heart medications or different things that you're taking, maybe cancer meds. But we're going to be in the donut hole. In the donut hole, we pay 25% of the retail cost of the medication. We just simply have a flat copay. And while we're in this particular stage, they're tracking another number, which is called TROOP, true out of pocket. Just so you know, I don't like that terminology. I don't think it's a very good word for this stage, but that's what Medicare calls it. But the number next year for the TROOP is $7,400. Now, what I want you to understand about the TROOP and why I don't think that's a very good terminology for that is that $7,400 is not money you spend out of your pocket. It is all that you've spent here, 25%. It's everything that you spend here in stage 1 and 2, all right? But here's what happens. What's also in here is the manufacturer of the brand name medications, the expensive ones that put you here in the first place. They have to discount those medications a full 70%. And that 70% that they discounted is going to go into the $7,400 as well, okay? So my whole point is, even if you do get to the gap, out of pocket, you may have spent maybe $3,000 of your own money. You certainly did not spend that $7,400, okay? Not minimizing the pain of the donut hole, the coverage gap, but it's definitely not $7,400 out of your pocket. And then that brings us into stage 4, and this is called the catastrophic stage. And it's real simple because here we pay the most we ever pay is 5% of the retail cost. So you could be on a $1,000 a month medication retail and it costs you $50 out of pocket. So nobody complains really about that stage, or that stage. It's just that stage 3 donut hole that can be painful. All right? And so this is the structure of all your prescription drug plans, whether it's standalone or whether it's embedded within the Advantage plan. But because you're diabetic, you're going to deal with the issues of medications, and we want to make sure that you have the right diabetic medication plan.